Welcome to the OMMedicine's module on thrombotic thrombocytopenic purpura. So thrombotic thrombocytopenic purpura, or TTP as I will call it from here on out, has many different forms. However, the most commonly tested form for your exams is going to be immune TTP, and therefore that is going to be what we talk about for the rest of this module. So TTP is going to be caused by a deficiency or a decreased activity level of Adam's TS13 protein, and it's very important to remember that this protein is responsible for cleaving polymers or clumps of von Willebrand factor. So because we have decreased activity of the Adam's TS13 protein, we will not be able to cleave the von Willebrand factor polymers, and these clumps of von Willebrand factor will persist in the blood, and this will lead to occlusion of small blood vessels, and then the occlusion is going to cause lysing or shearing forces which result in destruction of red blood cells, and this is what we call MAHA, or Microangiopathic Hemolytic Anemia, and we'll talk a little bit more about this in just a minute. So the presentation of TTP is somewhat nonspecific, although we will have fevers, we will get purpura and petechiae, which are the result of thrombocytopenia, and then we will also get these classical neurologic symptoms, so we can get altered mental status, confusion, headache, and even seizures. Now, because the presentation of TTP is somewhat vague and has a lot of overlap with other thrombocytopenic conditions like hemolytic uremic syndrome or ITP, we are really going to rely on the laboratory findings for the diagnosis of TTP. Now, I've listed some of the laboratory findings that you would expect to see in a patient with TTP here, and so obviously we would expect to have a low platelet count or thrombocytopenia, hence the name thrombotic thrombocytopenic purpura. We would expect to see a normal PT and PTT because this is not a disorder of the coagulation cascade or a deficiency of any of the factors in the coagulation cascade. We will have an increased bilirubin level, and we will also have an increased reticulocyte count. And this should make sense to you because the von Willebrand factor polymers are causing constant destruction and shearing of red blood cells, and so in order to meet the body's demand for blood, we have to constantly increase production of red blood cells, and that is why we will have an increased reticulocyte count. Now, we'll also expect to see the laboratory changes that are consistent with MAHA, or Microangiopathic Hemolytic Anemia. Now, we talk about MAHA in a separate module. However, some of the labs that would be consistent with this are going to be an increased LDH, a low haptoglobin, and then a negative Coombs test. Now, it's important to be familiar with all of these lab findings because many times questions will describe a clinical scenario in which a patient has TTP and ask you how each specific lab will change, or they will ask you what the expected laboratory changes would be, and therefore you have to be familiar with which values will increase, decrease, or stay the same. On a peripheral blood smear, we would expect to see schistocytes, or the fragmented remains of red blood cells, and this should make sense to you because these von Willebrand factor polymers are not being broken down, and therefore they're causing an occlusion of small blood vessels, and they will destroy anything that passes by them. And so the red blood cells will pass by these von Willebrand factor polymers, and they will destroy them, which results in schistocytes. And if you see schistocytes or the question stem mentions that a patient has schistocytes, it should be a huge clue that you're typically dealing with one of three conditions, and those are going to be TTP, hemolytic uremic syndrome or HUS, and then DIC. And then finally, we can also do an assay to test for the functionality of Adam's TS13, and as we would expect, it should be low in a patient with TTP. We can also use the percent of Adam's TS13 that is functional to further classify the severity of TTP. However, that goes a bit out of scope of this video. Now let's talk about the management of TTP, and the major way that we will treat these patients is with plasmapheresis. And it's very important to note that if we have an unconfirmed diagnosis of TTP, but there is a high degree of clinical suspicion and the labs are consistent with TTP, then we should still treat these patients anyway, because if we don't, they become high risk for a lot of the complications which can be deadly. Patients with TTP can also be treated with steroids as well as with monoclonal antibodies, and there are two that are typically used. The first is going to be Rituximab. Now, Rituximab is not routinely used in the management of TTP. It is reserved for patients who have a confirmed diagnosis of TTP, and that it is actually a severe case of TTP. There's a second monoclonal antibody called Caplicizumab, which is actually a monoclonal antibody against von Willebrand factor, so that von Willebrand factor cannot bind to platelets, and therefore we do not get as much microthrombi formation, and therefore we are going to prevent a lot of the complications in TTP, such as MAHA and microvessel occlusion. Now, this is a newer drug, so it's unlikely to show up on your board exams. However, this is something you should be familiar with for clinical practice. And finally, if a patient's platelet levels continue to decrease, you are allowed to transfuse platelets. There is an old belief that if you were to transfuse platelets, it would only worsen the symptoms and the severity of the disease. However, that is not true, and there are several studies to show this. And so if a patient meets platelet transfusion criteria, then it is okay to transfuse platelets. But one other clinical pearl is that the platelet count is sometimes used to evaluate the response to treatment, so it's not uncommon to recheck platelet levels throughout the treatment regimen and see if they are improving. And I'll end with this slide on the complications associated with TTP, and it's important to note that a lot of these are associated with delayed treatment. If plasmapheresis is initiated at the time of diagnosis, then these complications are going to be less likely. So a lot of these are going to stem from ischemic issues, likely due to the microthrombi causing poor blood flow, as well as the shearing of red blood cells. But neurologic complications can sometimes be a presenting factor, but they are also a complication. We can get cardiac ischemia due to poor perfusion to the heart. We can get renal failure, and then sometimes in severe cases we can also have death. And that brings us to the end of this module on thrombotic thrombocytopenic purpura.